Hi everyone, thanks for listening to my presentations. Today I'll be talking about tuberculosis in children. Tuberculosis in children. Epidemiology. About 10% of the total TB cases worldwide are related to children. That is World Health Organization in 2019 estimated about 10 million cases worldwide. And at the same time, they estimated that about 1.1 million cases would be in children. And they also gave us the record that 13.8% of all tuberculosis deaths are related to children. It is worse in kids with HIV. Still on epidemiology. In less than 5 years old, latent tuberculosis infection will progress to pulmonary tuberculosis, and from there, progress to extrapulmonary tuberculosis and severe forms like miliary TB and TB meningitis will occur more in this age group in less than 5 years. Children are infected because of adults. The adults will serve as the contact, particularly the parents or caregivers. About half of the cases in children will be found in those between the ages of 1 to 4. History of TB in children should include all the points that I'm going to mention when it comes to the clinical features or the symptoms of TB in children. But because I don't want to duplicate the effort, that's why I will not go over all of them here right now on this page, because you will come across all of them again when it comes to the clinical features. So please put that in mind. But for now, the history should involve the contact. We should know who passed this to this child. So whether the parents or the caregivers or from daycare or school, anywhere, we have to trace the contact. Then we have to know the history of tuberculin skin tests done in the past, the IGRA, nucleic acid amplification test, and if chest X-ray was taken in the past and what the outcome was then, we need to know now. Any sample culture done in the past and what is the result. The growth chart, we have to see the pattern of the growth because we might be concerned about failure to thrive. So we need to see the growth chart, from the time the woman had been taking the child to see the physician and the growth chart had been taken up to date. We need to see the pattern. HIV screening will be helpful, particularly nowadays that HIV and TB are two good friends that are not helpful to their victims. Thorough physical examination will be done, just like we would do in adults. The clinical features. It's not compulsory. I'm going to find everything that I'm going to talk about here in one child, but let's go through. Pulmonary tuberculosis, intrathoracic adenopathy, cough greater than 3 weeks, fever greater than 38 degrees Celsius for about 2 weeks, failure to thrive, weight loss. Kids greater than 5 up to 10 years old may have silent diseases. I said in previous slide that kids less than 5 will suffer the most and 1 to 4 will bear the brunt of it. Radiological investigation will diagnose cases in some 5 to 10 years old. Still on clinical features, extrapulmonary tuberculosis is very common here. 1, there could be lymph nodes involvement, lymphadenopathy, or lymphadenitis. CNS could be involved, and when we have CNS involved, it could be TB meningitis, could lead to complicating hydrocephalus, could lead to stroke, or increased intracranial pressure. We may be dealing with pleural effusion or TB pericarditis with pericardial effusion. Still on clinical features, When the abdomen is the organ affected, we can have abdominal tuberculosis, giving us pain, jaundice, ascites, particularly when the liver is involved, and could also lead to diarrhea. TB adenitis will give us painless, fixed, enlarged lymph nodes, particularly in the cervical region, with or without fistula formation. Still on clinical features, the TB could affect the joint, TB of the joint. Vertebral tuberculosis will give us gibbous deformity, and skin with whitey papilloneurotic lesions, and kidney involvement will lead to hematuria and sterile pyuria. When the eyes are involved, we can have inflammation giving us conjunctivitis or iritis. Congenital tuberculosis. Well, this is because I'm dealing with TB in children. There's a separate presentation on congenital tuberculosis. Check my channel for that. So I will not waste your time giving any explanation here because I've given details about congenital tuberculosis in a separate presentation already. Kindly check my channel for that. Well, briefly, it's going to lead to about 50% mortality. That is horrible, right? But good news is rare. We don't even want it. Associated with TB endometritis or disseminated TB in the mother is spread by placenta or by fetal aspiration of the amniotic fluid containing the Mycobacterium tuberculosis. The clinical features of congenital tuberculosis will include respiratory distress, fever, hepatomegaly, splenomegaly, poor sucking, lethargy, and irritability. The diagnosis of congenital tuberculosis will include the skin test, HIV screening, chest X-ray, lumbar puncture, and have CSF sample taken for AALB, NAT, and placenta sample for histology, ALB, NAT, IGRA. Neonatal tuberculosis can follow postnatal exposure and is more common than congenital tuberculosis. Please check my channel for all these pieces of info. We need to evaluate the mother in both congenital and neonatal tuberculosis. When it comes to diagnosis of TB in children, we'll be dealing with paucibacillary, that is, few bacilli, non-cavitatory pulmonary disease, and bacteriological confirmation in less than 50%. Samples culture is better, but sputum expectoration may be very difficult, particularly very young children, right? Gastric aspirate is therefore used mostly. Lumbar puncture is mandatory so that we're going to get the CSF, okay? And whole blood sample, bone marrow specimen, lymph node biopsy to rule out lymphadenitis, urine sample, and pleural fluid to rule out pleural effusion. Adenosine deaminase could be used, and you can use the dose of over 40 international units per liter in the pleural fluid in majority of the patients. You can also use expert MTB-RIF. It's a nucleic acid amplification test that will detect Mycobacterium tuberculosis and also detect rifampin resistance. You should rather use IGRA in greater than 2 years, but may not give a true picture in overwhelming immunosuppression. And somebody will ask me a question, why that? Because you expect children in endemic parts of the world to have BCG at birth. So now you want to be sure this child is not having tuberculosis, and the mother or the father will be yelling, no, the child had BCG, that your TST may not give true picture. Don't worry, just go for IGRA right away. Radiologically, chest X-ray should be done, PA and lateral. You can have CT chest done if you are lucky enough to have that. You can have urine antigen or urine lamp, that is lipoarabinomannan. The treatment, there's nothing different from treatment in adults except the dosage that will be in milligram per kilogram. So check my channel for the treatment of tuberculosis in adults, and I will just brush over this here. INH, rifampicin, pyrazinamide, and Timetable for the first 2 months, then limit it to INH and rifampicin for the next 4 months. But in TB meningitis or osteoarticular tuberculosis, you can give INH and rifampicin for 9 months. And in central nervous system involvement, you can use streptomycin or amikacin or etonemide in place of ethambutol. So, for example, if there is TB meningitis, you can give INH, rifampicin, pyrazinamide, and amikacin or streptomycin or etonemide. Don't use ethambutol. Pyridoxine is not often given in kids, but it's good for exclusively breastfed infants and also in those with HIV infected or malnourished children. But in children with multi-drug resistant tuberculosis, we should try bedaquiline in 12 to 18 weighing 30 kilograms. Prevention: BCG immunization, treat latent TB, and prevent it from progressing to pulmonary tuberculosis and extrapulmonary tuberculosis. Educate and evaluate caregivers and parents, and treat promptly. The timetable of tuberculosis is essentially that the incubation period will last for almost 3 to 8 weeks. There is primary tuberculosis that will be within the first 1 to 3 months. Miliary tuberculosis and TB meningitis is likely going to occur in the first 2 to 6 months, and TB infantinitis in 3 to 9 months, TB pleural effusion in 3 to 9 months, TB affecting the bones and joints will occur several years after having primary tuberculosis, and renal and genital tuberculosis will occur in over a decade. And with that, I've come to the end of the presentation on TB in children. Please subscribe to my channel, share this, and leave your comment. I appreciate it. And you can check my channel for other presentations on tuberculosis and other subjects. Thank you.